So we're going to jump into our first case here because we haven't talked a lot about young kids. And this is something in orthodontics that is very, very controversial, all right, still to this day. For me, like, I don't know, like, I have a hard time understanding why it's so controversial, but it is. Like, you know, if you talk about expanding a 4 or 5-year-old, like, there's a lot of orthodontists out there that just get really, really upset about it. And my question would be, you know, why? And historically, I can kind of understand it because, you know, it's very difficult to know the growth that was going to happen, and it was difficult to manage patients like these sometimes with the expanders that we had. And also, it was hard. The argument has always been like, well, if you can do it later, just do it later, right? And so this goes back to the whole kind of airway debate. You know, when does this affect airway? Like, how much does it affect their sleep and all those things? And those are still things that are under, you know, scrutiny and still research that's coming out. But this is actually, this is my son. So this is the first time that I kind of saw my son in the office, and he was about 4.5 at this time. And we didn't expand him right at this time. But when you look at this case, like, what do you see? Like, if you just saw this kid in your office, and we can ask the pediatric dentist too, like, is there any red flags here? Like, that you're seeing? I mean, what are you noticing or not noticing? Is there anything you are worried about when you see a kid like this? Or are you thinking like, hey, just let him grow and it'll be fine? Okay, so the crossbite where? Lower right, so like over here. Oh, there we go. Over here? Yeah. So it may be a little tight. I don't think it's in a complete crossbite. What else? I mean, yeah, so I mean, it seems like we have pretty decent spacing. I mean, we have spacing. We have some spacing. So, I mean, how decent is it? Not really sure, but we have some spacing on the top and the bottom, right? What else? Well, what's right then? Or what's wrong? What's wrong? Is there anything wrong? Is there anything you'd want to see different and see better? How about our vertical dimension? What does our vertical dimension look like? What? I see some mouthing of things. Okay, so possibly a little bit end to end, all right? Maybe that indicates a little bit, you know, either maxillary retrusion or mandibular prognathism, possibly a little bit tight, edge to edge here. When we look at his profile, there's not a lot wrong with that, I would say, right? It seems like the upper jaw is forward. We have a kind of a more normal nasolabial angle. It looks full there, so no real issues there. What about his smile? Like, what do you like or not like about his smile? I mean, he's 4, so he's got a cute smile, right? And he's my kid, so I can say that. But, you know what I mean? If you're getting picky and saying, hey, what could be better about the smile? Like, starting from an ideal standpoint, like, what could be better? Yeah, you could increase the incisal display, right? Even at full smile, you can see he's showing about half of those baby teeth, okay? So now we'll just take a poll. Like, if this were your kid, like, how many of you would be like looking at this and saying, like, I want to expand them? Nobody? All right, so then how many of you would not expand them? Okay, the vast majority of you. Okay, so let's keep looking. All right, so now we have our x-ray, okay? So now we can see, again, 2D, right? But we can see the teeth that have come in, the teeth that haven't come in. We can see they have all the teeth, which is good, the ones they should have by now. Okay, anything we see here? Any red flags? I mean, I know that at least the orthodontists in the room, they probably don't look at a lot of 4-year-old panos. But is there anything that stands out to anybody, negative or positive? Not really. Any big red flags anywhere? I would agree. Like, there's nothing like super out of the ordinary with what we're seeing here from an eruption standpoint. You know, this is typically what we would see. All right, so now let's look at this view. And this is a view we haven't covered a lot together, but this is probably the view that as you move forward and as you're taking cone beams on your patients is going to be one of the most important views. So who can walk me through what we're seeing here? What are we measuring here? Skeletal transverse discrepancy, okay? Now, obviously this is in a 4-year-old, So this is not the final skeletal transverse where it's going to be. There's going to be growth. Is there going to be more growth in the maxilla or in the mandible, talking about the transverse, or is it going to be even as he continues to grow? Again, he's 4.5 at this point. Yeah, there's going to be more growth in the maxilla, okay? From about the age of 7 until growth is complete, which they say around, the study that was done, the Iowa study was done about 26, you're going to get about 4 millimeters of maxillary transverse width of the maxilla versus about 1 millimeter in the mandible, mostly owing to it coming forward, if that makes sense. So the body, the width of the mandible that matches with the maxilla will be a net of 1 millimeter wider, and the upper will be a net of 4 millimeters wider, okay? So he's 4, so let's just say that that's another millimeter. Let's say he gets 5 millimeters on the top and a millimeter on the bottom, so relative to where he's at, that's 4 more millimeters. That would put him at 46 millimeters on the top and 47 millimeters on the bottom. What should it be? Or if you want to argue about what should it be, what would it have been 1,000 years ago, before the advent of modern faces, right? When prehistoric skulls used to keep their wisdom teeth and all that kind of stuff. What would it have been when he was done growing? How big would the transverse maxilla be compared to the mandible? The difference. How much bigger would the maxilla normally be than the mandible from a skeletal standpoint in the transverse, ideally? Yeah, 3 to 5 millimeters, okay? So we do the math here, right? So best case scenario, we get him up to, like, let's say 46 on the bottom, or 46 on the top, still 47 or 48 on the bottom. We're still, absolute best case, we're going to end up even, all right? And most likely, we're going to end up a little bit deficient on the top. Now, you already looked at his clinical images, so we're not really worried that we can't deal with that later, right? We could deal with it later. Like that amount of a transverse discrepancy we deal with all the time. Or you go to any ortho clinic, you're going to see patients in that clinic that have a 3 to 5 millimeter discrepancy, and we just deal with it. We tip the teeth out on the top, we tip them in on the bottom. It's happened so commonly. They termed what used to not be a normal thing, and they call it the curve of Wilson, right? So the lower teeth tip in, the upper teeth tip out. They named it so it sounds normal. But this is not something that typically used to be present in skulls before modern skulls. So now we know we have a jaw size discrepancy. And we know we don't have to correct it, right, from an orthodontic standpoint. But now we start asking other questions, like, how is the child sleeping? Is there snoring? Is there bedwetting? What else is going on with that child? Is there severe allergies or congestion, mouth breathing, like all these other kind of things? And does that factor into your decision-making process? From my standpoint, with my kid, it makes sense to get the jaws as ideal as possible as early as possible, right? The faster that these jaws are ideal, the more time Mother Nature is going to have to bring the teeth in the most ideal way possible. And if there is any benefit from a health or airway standpoint, I would rather them experience that benefit earlier than later. So if this child was not my child and came into my office, I would explain it just like that. I would say, hey, look, there's a jaw size discrepancy. You don't have to do anything about it. Some people have a jaw size discrepancy their whole life, never caused them any problems. And other people have them, and it does cause problems. Later on, what dental problems can jaw size discrepancies cause later on in life, like after all the permanent teeth are in? All right, we've compensated, we've tipped the upper teeth out, we've tipped the lower teeth in, we've got everything to fit together. Are those patients at a higher risk for dental problems than patients who have an upper jaw that's 3 to 5 millimeters wider? Yes, disproportionate wear tipping, breakdown of teeth, higher incidence of TMJ. So there are things that happen when we leave a jaw size discrepancy in general. Like if you look at the numbers as a whole, individually, you might get lucky, you may never have those things. But when you look at the overall numbers as a whole, if you have a jaw size discrepancy your whole life, you are more likely to experience dental problems, even if you take out, in my opinion, the sleep issues, which, again, as more and more research comes out, more and more research tends to support that these issues are related. And the better a child can breathe anatomically, the more room there is when there's a jaw size discrepancy. I'm not saying that if a kid has sleep issues and there isn't a discrepancy, you should expand them. There's no data to support that. But if they do have a discrepancy and they're having these sleep or airway issues, there's a lot of emerging evidence that's showing, hey, you're at a minimum going to be able to breathe easier, be able to nasal breathe easier. And we know that if we can get them nasal breathing versus mouth breathing, there will be improvements. Okay, so this is his expansion. This is what this looked like. And I had mentioned the cross elastics that we use sometimes, and this is what those look like. So you can see here, they go from the inside to the outside, and the purpose of those cross elastics is to upright the posterior teeth so that when the expander comes off, there won't be a buccal crossbite. Because when you look at a transverse discrepancy that is this big, if we expand this completely, I mean, our goal would be to get, 5 millimeters to 6 millimeters of skeletal expansion. That's going to push them into a buccal crossbite if we don't do something with the back teeth. And so you can see these are connected to the E's. So we're going to run those cross elastics while they're expanding. And as luck would have it, this is the progress here. You can see here that as that expansion happened, you could see how much spacing was created between those baby teeth. You can see that the interseptal fibers between the teeth have started to pull those together. We're starting to get some tipping of those primary teeth. And as luck would have it, this was all happening right around the same time that my wife wanted to do family pictures. And so I was looking at my kid and I was like, oh man, this is kind of like, this kind of doesn't look so great. And this picture is going to be hanging in my office. I'm like, hey, I got an idea. So I am, I've bonded teeth before. We learned how to do it in dental school. I still do some, temporary cosmetic bondings for patients with small teeth to help us through orthodontics. I'm like, hey, we got family pictures this afternoon. Let's just run to the office real quick and take care of this. And so we go in, and my little 5-year-old, he's like, whatever, Dad, it's cool. And I'm like, okay, we got you, son. We're going to take care of this. And I kid you not, like I didn't see it. Like I didn't see it afterwards. And I'm in a hurry, and we're like, okay, I don't even know what these are. I don't even call it baby teeth, like maybe teeth. Maybe they're baby. I have no idea what to even call these things. But, I took something that was actually not so bad and made it permanently memorialized in our family photos forever. So, poor little guy. He'll have a fun story to share. Eventually, I did see it, and I'm like, hey, that was not great. And we did kind of cut those back and made them look a little bit more normal. But that was my learning experience with bonding baby teeth. So. Yeah, so honestly, I don't even remember. Now I will turn every other day. Like, you don't need to turn more than that in a 5-year-old. Like, it's going to open up significantly. So I don't think there's anything bad with turning every day. When you look at the research, like they always, critics of early expansion will always quote like Prophet's research about like if you expand too fast in a kid, you can cause nasal deformity, which is true. But when, they're talking about 4 to 6 turns per day. Okay. Now again, we weren't usually expanding 3 or 4-year-olds. So if you're expanding someone even younger, yeah, could 1 turn per day mess something up? I don't know. I've never seen it. I still don't expand a lot of 3 and 4-year-olds. For me, my favorite time to expand is right before the 6-year molars come in. Because if you can identify the discrepancy and you can expand with the primary dentition, then the 6-year molars come in upright. They don't compensate. So you don't end up having to correct those, the transverse discrepancy of the molars. They come in upright in the bone, and then that kind of sets the stage for all the rest of the permanent teeth to come in. And then also, like I say, the resistance of the skeleton is very low at that point. But look at the changes in so far. I mean, we know we have transverse changes, but look at the vertical changes. So, I mean, you can see how much vertical change of the maxilla there was just by correcting this transverse discrepancy. You can see here still we have tons of space. This was right when the expander came off. On the bottom here, these are the bite ramps that we'll do sometimes. So you can see here, even with those lower cross elastics, we still had the upper jaw in a buccal crossbite essentially. So we ended up putting on these bite ramps. What these bite ramps do is just, basically hold the bite open, and they create a ramp here so that when he bites down, it pushes those lower E's out further. And then we'll let that go for 6 months or so. And after the lower teeth are out, then we'll take that off, and hopefully around that time we start to see the eruption of the 6-year molars. Okay, so that was afterwards. So let's go ahead and we're going to continue to fast forward now, but I want to show you our skeletal jaw width now. Okay, so you can see here we've gotten about 5.5 millimeters of skeletal expansion. This image was taken immediate debond of that expander. So again, now if we have 4 to 5 millimeters of maxillary growth, we know that we're going to end up with an upper jaw that's 4 to 5 millimeters wider than the lower jaw. This is what that looks like from a 3D superimposition standpoint, so you can appreciate the increase in the vertical of the maxilla there as well. So now we'll fast forward. So this is when he was 6 years old, okay? So we can see here that the space is consolidating to some extent. We still have those bite ramps on the lower. He's kind of biting funny in that picture. He's not even biting down on them. But you can see here, again, the vertical increase of the smile display. And his smile might be a little bit different than it was initially, but certainly you can see a change there. Looking at the pano, so you can see those baby teeth were still tipped inward. So the reason they didn't look tipped inward is because I had those bondings on them, and when I shaped them, I just made them look like they weren't tipped. But you can see the teeth are still tipped. You can see that there's plenty of space for the central incisors. At this point, this is about 6 months post-treatment. Those teeth have not moved together yet into that new area of bone. So let's keep going. This is 7 years old. All right, so you can see here again, now we have the 6-year molars coming in. You can see that the buccal occlusion on the E's is now normal. So those have compensated, combination between top and bottom, it looks like. And the 6-year molars are coming in. You can see again the vertical. So with these younger kids, I will try to hold them for 6 months and then not really. Yeah, just kind of let it settle in. Yep. So because that's a long time to have a retainer. Yeah, from like 5 until 12 or something. Right. It's basically as soon as that posterior occlusion is stable, like it's not really doing much. So yeah. All right. So this is the 7-year-old progress. All right. So now we've got the permanent teeth coming in on the bottom. And we'll start to look at those centrals. You can see those are starting to use up some of that space that we created on the top. And then here is the 8-year progress. So this was taken earlier this year. And you can see now the permanent teeth are in on the top. You can see we have the lower 4 incisors in, and we're starting to get the rest of the permanent teeth in. And we've, again, like, it's interesting as he's continued to grow, and maybe part of it is his smile, but like, I would have guessed we would have had even more vertical display based on where we finished with the maxilla. When you go all the way back to when he was 5.5 and the expander came off, it looked like there was like almost too much vertical, but some of these things normalize out over time. All right, this is where those permanent teeth are now. You can see they're continuing to come in. There's plenty of space. And again, when Mother Nature has space, it does a pretty good job of getting teeth in. So you can see here, I mean, maybe a little bit of crowding. Again, we're just watching at this point. A little bit of rotation of the central incisors. But overall, not too bad. Okay, any questions on his case? All right, we're going to take a little aside. Now, what I did is earlier on in my practice, you know, the concepts of expansion and whatnot, they always resonated with me, but I wanted to know more from a practical standpoint, like how important are these things? So I did a survey of our own patients. So at our practice, we have, you know, we highlight our best smiles, right? So we take pictures and we have them on our walls and things like that. And so what I did is I wanted to do a survey and see, like, you know, out of our best smiles possible, like how many of these patients did have early treatment versus didn't have early treatment, and what types of treatments did we do? So basically trying to reverse engineer, like, well, let's start with our best results and then work backwards and see what we actually did. So at the time I did this, there were 63 patients total that we were looking at. So these are the smiles that we had displayed on the walls at the time. And so the percentage of those patients who came in and were seen at 10 years old or younger, and the reason I demarcated that is I wanted to see, like, you know, how many of these patients came in at a time when we could make a significant, you know, skeletal change as needed. And out of my best patients, 76% of them did come in earlier. Okay, so we had an opportunity to do treatment if needed. So now when we take out that subset of patients who came in early and we'll just look at that group, okay? So what percentage of those patients actually had expansion? It's about 60%, okay? So a little over half, all right? So you know, almost half of them by default didn't need expansion, or we didn't do expansion on. The percentage that had early braces, relatively few, about 17%. Again, most of the time, I don't jump in with early braces unless there's a big issue or something else is needed, but you know, close to 1 out of 5 we did early braces on. The percentage that had baby teeth extracted, and we'll talk a little bit more about this today, actually 97%. So pretty aggressive in getting teeth out of the way when permanent teeth are erupting or needing to come in. And that could have just been like, you know, helping one tooth out early, but basically having some sort of guidance in making sure that the baby teeth come in the way that they needed to. And then out of those 63 patients, the number of patients with permanent teeth extracted was 1. And it was actually one of these siblings here. So we had treated all 4 of them. And most of the time when I put this photo up, like who would you guys guess that had them extracted if you had to guess? Top right? Okay, any other guesses? The guy, yeah, that's probably the guess that we get the most. It was actually top left there, so yeah. But we did do expansion prior to extracting. There was just too big of teeth and too much space loss and still to fit within the jaws that she had, so we did end up extracting. But if you do extract after you've already corrected a jaw size discrepancy, as long as you close the space forward and you're not retracting, then you're not really going to be able to tell when that happens, okay? Now, one of the things that the pediatric dentist has asked a lot about over the years is traditional space analysis. So when we talk about space analysis in like the cases I show you, we can look at it from a 3D standpoint. Probably one of the best ways to determine how much space you have is if you were to send off a cone beam and section all the teeth and create digital files and do a digital workup, you can tell exactly how much crowding that you have. Now that's still, even to this day, not super practical. It takes a long time. So we want to understand different ways of how we can know how much crowding or spacing we're going to have. So we're going to talk a little bit about space analysis and mixed dentition analysis, okay? So when we talk about the mixed dentition analysis, this is traditionally how orthodontists have predicted how much crowding or spacing that we're going to have. So basically what you need is the permanent teeth on the lower anterior and the upper anteriors, and then you can determine how much likely space the rest of the permanent teeth are going to need in order to come in. So once the incisors have come in, the mandibular arch length and width have achieved the adult dimensions, okay? It qualifies this with for all practical purposes, all right? I just need to take a quick aside here and show you why that's important, because this will help to understand why they put that little qualifier in. So this is a visual diagram of the growth between 7 and you can see 26.4. I mean, for all intents and purposes, the vast majority of it's done really by about 16 to 18, depending on boys or girls. But this visually shows you the changes that we see in the maxilla and the mandible at the level of the first molars here. So you can see, you know, quote unquote normal, meaning modern day normal, is that as the upper jaw widens, you can see that this relationship between the top molars and the bottom molars is maintained. So there's a lot of confusion about this because as orthodontists, sometimes we're taught that like once the 6-year molars come in, like that width is the same. Like it's just going to be like, that's what it is. And where that comes from is that if you look at where the upper and lower molars are when the child is 7, as the jaw grows, if they're interdigitating here, they're still going to interdigitate here. So as the upper jaw grows, the upper teeth upright. So there's not a net change in the transverse dentition, if that makes sense, of the maxilla. So the whole point of teaching people that is that if you see, like I say, for instance, a bilateral or a unilateral crossbite in a 7-year-old, they're not going to grow out of it, okay? And they won't, right? But where that gets confusing is that some people take that to mean like, oh, the maxilla is done growing at 7, which is not true, okay? There's still, like you can see, quite a significant couple millimeters per side growth of the maxilla between 7 and 26, whereas you don't see that very minimal growth, about a millimeter total, half millimeter per side of the mandible with just very slight uprighting of that mandibular dentition here, okay? So that's that's what you want to understand from a growth standpoint. So let's look now at this space analysis tool and help us understand what's going on there. Okay, so arch length and width have achieved their adult dimensions, meaning, you know, the teeth themselves, not necessarily the jaw. And so the idea is that you can, if you have a study cast, this was back before digital imaging and everything like that, there's a couple different analyses. You can do a Bowley gauge dental cast and a probability chart, and you can get an idea of what those are going to be. So this probability table for prediction is basically based off of like the mean, right? About the 70, it's going to work about 75% of the time fairly accurately. And then 25% of the time it's going to be off one way or the other, all right? So it's kind of the whole bell curve idea. So before we go into that, I want to make sure everybody's comfortable knowing how to read a Bowley gauge, because that's important if you're going to be doing this. So let's go through this briefly.
Good morning, team. So
this is one I put together for my
video
team,
comes
but
by request, and it's how we measure for the expansion and how much expansion we've gotten. So the first thing we'll do is we'll look at how we use our calipers, because that's going to be the first thing to know in order to know how to measure. So when you look at this caliper here, you can see that this initial line here is lined up with 0. So this initial mark right there, let's see if we can zoom in and get that even closer. Yeah. So this initial mark is what's used to determine the millimeters. So if that mark goes forward to, let's just say here, you can see that this is opened up. This is the spot that it's measured. And now this is at 2 millimeters. And this first mark is telling us that, okay? So if we moved it all the way to here, you would see this was 10 millimeters, this big mark here, and then but this little mark is right here on the next one, which is 11 millimeters. So if you're measuring in millimeters, that would be how you do it. That would be 20 millimeters, 25 millimeters, 26 millimeters, okay? So the question now comes, well, how do you know if it's in between the millimeters? So let's just say we're at 1, 2, 3 millimeters there, but then let's just say that it's in the middle somewhere, okay? So it's not quite on the 3, not quite on the 4. I mean, you can look at it and guess. You could say, okay, well, if this is 3 millimeters and this is 4 millimeters and that mark is right there, that's, you know, around 3.2 or 3.3. But the way we're supposed to do it, and the most accurate way to do it, is to look at these other marks now. So you already know the millimeters, you're at 1, 2, 3, that's not going to change. Now you look at these marks to determine how far in between the 3 and the 4 you are. And what you're going to look for is you're going to look to see which of these lines lines up the best. All right, so you can see this one doesn't line up, this one doesn't line up, this one doesn't line up. When you get to here, it looks like it pretty much lines up. This one might be a little bit in front of it, but when you get to here, it looks like it lines up pretty perfectly. So I would say this is the line that lines up the best. And as you can see, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 marks down here. So you know that this is 3, because it's here, 0.5, because 5 is the line that lines up. So when you go further, let's just say now, so now we're at 6 point something, okay? So here's the 5 mark, there's 6, you know your first mark's after 6, but not quite to 7, so it's 6 point something. If you want to know exactly where it goes, just count over the marks until the one lines up. So these all don't line up, don't line up, don't line up, don't line up. When you get to here, it looks like it lines up. So what mark is that? 1, 2, 3, 4, 5, 6, 7, 8.
Okay, any questions on how to use the caliper? All right, so use the caliper, and they have digital calipers now too, which makes that a lot easier. But if you still have those in your clinic, that's what you're going to do. So what you're going to go through and you're going to measure the mesial distal widths of all of your lower incisors, and you're going to add those up. Okay, so you get the grand total, and then also you're going to mark the mandibular midline, and so you'll take all those measurements, and basically you can put those on your cast at where those teeth are going to eventually be. Okay, so in this case you can see that the plan was to move those lower anteriors forward, at least 3 of them that were further back, and we're going to shift the midline over to the left. So we know where those incisors are going to be. Now we need to know how much space we have. So whatever we have from distal of those lines to mesial of the first molars back there is the amount of space that we have available, okay? So that's how you determine the space available using this method. Now, if the permanent teeth require more room than that, then there's going to be a discrepancy, and the difference between those two is going to be your amount of crowding, okay? So this is the chart. Those are the measurements. You can see here, right here, those are the teeth that you're measuring. This is the total combined width, and then that's going to show you how much room you need based on that. And they have the predictability charts to do that. Okay, so advantages of doing this, said it has minimal error. I think that's, again, in 75% of patients or so, it has minimal error. Can be done with, equal reliability. It's not too time consuming. No special equipment required. Can be done in the mouth as well as on a cast, although I think it's a little bit harder to do in the mouth for sure. And again, it's a probability analysis. It also doesn't account for the tipping of the incisors unless you measure that out on the cast like we showed you there. All right. Also, it doesn't mention the group of people that these norms were taken from. So cross-culturally, will this hold up? Not really sure. On Eastern European? Yeah. So again, does that translate over to other? Yeah, maybe not. Maybe not. So this is a way that you can look at patients in 3 dimensions. So this is what I was talking about, where how you can section teeth. And you can actually move these teeth digitally and see what the spacing requirements are. In addition to just looking at spacing requirements, you can also 3D treatment plan. If you want to do expansion, you can program that in, how much you want to do, how you want to move the teeth, where you want to end up, vertical changes. So you can see here, these are all simulations that are possible with 3D treatment planning. Now this takes a lot of time to do currently. Maybe one day it'll be a lot faster and you could just throw it into an AI software and it would do all this for you. But currently it's kind of done by hand. But you can get a much more accurate space analysis by doing something like this, because you can see where the bones are, you can see the tipping of the teeth, where those would need to be, and you can see where things would end up in the final occlusion here. Have you guys seen that before? Have you seen the software before? Yeah, so that's called anatomage. Yep. So let's finish up with this case here. So let's diagnose this case. What do you guys see? Anything? Good, bad, indifferent? Okay, deep bite. What do we always want to look for when we see a deep bite? Lower incisor wear, okay? Now, again, I don't have a center open photo for this patient, but you can look here at the edges here, and it doesn't seem like too terribly significant, I would argue. I'm not seeing a big flat area. I'm not seeing, mesial or distal looking a lot more thick than the other. So we want to look for that, but definitely a deep bite. If we don't correct a deep bite, there certainly could be wear in the future, or you could also potentially, like the lower jaw, if it runs out of overjet, you're going to see that it has a harder time growing forward. Now, some would argue that it's going to rebound as soon as you correct that overjet, and I think there's some truth to that. So maybe that's a big deal, maybe that's not, but that's something to think about. All right, so what else besides the deep bite? All right, okay, so we have the mental labial angle here that's more acute, and why do you think that is? Okay, so retrognathic Manuele, you can see, and there's like a shorter chin throat. Neck length here, you can see, and we haven't looked at the Ceph yet, but if you can imagine, the lower jaw looks to be set back, and you have a definite, more class 2 relationship on the right, maybe a little bit more end-on the left, and so we have this presentation of the lower jaw being set back. So what does that mean at this point? Is that something that we're overly concerned about at this point in his growth and development? Like, is there something that we're going to do about it at this point? Yeah. So maybe, you could. You could do a twin block there, functional appliances if you wanted to. You could jump in and do that. All right, what else do we see? Well, talking about our space analysis, let's start with the maxilla. What would you say from a crowding standpoint, like mild, moderate, or severe, would you say in the maxilla, and why? Like, how do you make that determination if you don't have the 3D image and you don't have your caliper to measure everything out? Like, how can you get a rough ballpark just by looking at the teeth in the arch? Like, what landmarks can you use to help you determine is there significant crowding or not? Okay, significant. All right. So, what's that? Uh-huh. Yep, these are deciduous canines. Yeah. Yeah. So when I look at, if I'm just ballparking something, the way that I like to look at it is separate the posterior from the anterior and then measure it out. So in general, if you have all of your primary teeth, if you figure in the leeway space and you don't lose that space, then it'll be about a wash because your second molar is bigger than your second premolar. Your first molar is roughly the same size, a little bit bigger than your first premolar, and then the canine is smaller. But when you add that all up, it's about a wash. So when I see, 3 teeth on either side, that's good. Being, okay, great. Like that part's going to be taken care of. So now we can measure our crowding just in the anterior. And so, like you'd mentioned here, we've got maybe 3 millimeters or so of crowding here, maybe another one here, 4, 5, maybe 6 or something, okay? So definitely a moderate crowding case. Now, the only thing that doesn't take into consideration is the angulation of the teeth if we're going to change those, right? So if we're going to flare these teeth forward in their final position, then we may pick up some space there, right? So for every millimeter the incisors come forward, we get about 2 millimeters of space, okay? And in this case, these incisors do look upright. So maybe we move them forward a millimeter or so, pick up another couple millimeters of space. Maybe it's like moderate but more toward the mild side versus more toward the severe side. Now, what about the bottom? If we use the same logic on the bottom, how does our lower right side look? Looks fine, right? You have all 3 baby teeth, and you even have a little bit of space. There's space here, but it's also overlapped a little bit. So maybe you pick up some crowding here. But what about our lower left side? Yeah, we're missing an entire canine, right? So most likely what happened is when this lateral incisor came in, because there was crowding, it kind of took out 2 baby teeth, or he might have lost that baby tooth for some other unrelated reason, trauma cavity, something like that, and then everything tended to shift over to that left side there, okay? Now, how about vertically? How do we look vertically? Yeah, deep vertically from a dentition standpoint. What about maxillary vertically? I mean, we definitely have an appropriate amount of incisal display, right? We don't want a ton more than that. They're a little bit upright, so maybe as those as we flare those forward, that could change a little bit. Let's look at the pano now. What do we notice in the pano? Anything that we're worried about? So when we have loss of space for a canine, one of the things we worry about is potential for root resorption and or impaction, right? So taking those one at a time, from a root resorption standpoint, are we looking good or are we not looking good? And why? What's that? Yeah, seems okay, but what about it makes it seem okay? What are some of the landmarks you're looking at that says, hey, this is probably okay? Yeah, so it's mesial, or it's distal, right? The root is mesial of this. You can see the tip of the canine is not crossed over the root at all on either side. And so, could it impact? Yeah, it could. Mandibular impaction, not super common when it's coming up in the right space. More often than not, it may flare facially, it may flare lingually, it may rotate and come in, but usually they find their way in some way. Now, it may lose some of the buccal plate if it goes too far facially as that's coming in, but the chances of impaction are not super high. You can see and appreciate there, though, the amount of crowding that there is on the top that we mentioned. So we have crowding on the top, we have loss of space on the bottom. What are you going to do in a case like this? I mean, what's coming to mind? And you can pair that with the airway imaging. Again, I'm not like overly excited about this because this is a screening tool, not a diagnostic tool, but it kind of is something that we look at that's smaller than it would normally be in a child his age. And then we can look at the discrepancy here. Upper jaw should be 3 to 5 millimeters wider. We can measure that out. We can see upper jaw versus lower jaw. And if you put those two things together, you can visually appreciate how much bigger the lower jaw is than the upper jaw. You can measure that out, about 43 millimeters on the top, about 46 millimeters on the bottom. And so in a case like this, I'm going to expand. We'll get the upper jaw wider, and we'll let Mother Nature do her thing until the rest of the teeth come in. We are out of time. Any other questions for today? All right, perfect. You're welcome.